Hello and welcome to this edition of Medication Management. I am Dr. Amber Cann, and today we're going to talk about the many therapies that we use to treat and prevent migraine headaches. We have two lanes of the goals of therapy for migraines. First, we want to talk about acute symptom management. And then we also want to think about the preventive treatment. To control symptoms as they are occurring or as they begin to occur, our ideal treatment would be rapid onset and lasting long enough to deal with the pain throughout the migraine episode. It would not only treat the pain, but it would treat the aura of migraine, the other symptoms that go along with having a migraine. It would restore the patient's ability to perform normal activities and feel normal. It would have minimal side effects, and of course, it would be cost effective. For preventive therapy, we want to decrease the number of migraines the patient has per week, per month, per year, whatever our measurement of time is for that patient. We want to minimize the adverse effects of whatever drug selection that we make. We want to decrease the severity and the duration of the migraines that do occur, and this one should be cost effective as well. We can choose a specific medication that targets the migraine etiology, and we can choose some non-specific supportive therapy as well. The non-specific variety includes NSAIDs, Antiemetics, and anti-nausea medication to deal with the aura associated with the migraine, and corticosteroids. Specific to migraine are the Triptans and the Airguns. We generally limit the non-specific medications to mild and moderate symptoms, ones that cause minimal disability to the patient. We save the Triptans and the Airguns for symptoms that are moderate to severe, those that are causing severe functional disability to the patient. Certainly the most affordable and readily available medications for migraine are those that are over the counter. There are several brand names, and each of them includes a varying mix of pain relief and other ingredients. For instance, Excedrin migraine has acetaminophen, aspirin, and caffeine in it. The product that's labeled Advil migraine only has ibuprofen 200 milligrams in it. That's the same over-the-counter strength that you can find in regular variety ibuprofen or Advil. The Aleve brand doesn't have a specifically labeled migraine product, but on their marketing, they advertise the liquid gels as being appropriate for migraine sufferers. It should be noted that the liquid gels have 220 milligrams of naproxen, just like any other over-the-counter naproxen product. Tylenol alone isn't generally recommended because there just isn't scientific data to suggest that it's efficacious for migraine. Some of these products include acetaminophen, though, plus aspirin, which is an NSAID, and caffeine. It is approved over-the-counter in the U.S. to be labeled to treat migraines. There is some evidence that adding caffeine to the mix does help with some varieties of headache and migraine. It is so important, though, to educate patients about maximum doses and the risk of GI bleeding and other side effects associated with these products. Patients may not realize the ingredients, and it's easy to get to the toxic doses quickly. On that topic, I want to mention the maximum doses for ingredients typically included in over-the-counter agents for migraine. Acetaminophen generally is recommended to be taken 1 gram at onset of symptoms and then repeated every 6 hours as needed. The dose should not exceed 3 grams in a 24-hour period. For specifically the Excedrin migraine product that has a combination of acetaminophen, aspirin, and caffeine in it, the labeling states that the patient should take 2 tablets at onset and then repeat with 1 tablet every 6 hours as needed. Again, we max the dose out based on the acetaminophen content, and that's still 3 grams in a 24-hour period. Some people do get relief from aspirin alone, and the recommended dose for migraines is 1/2 to a gram every 4 to 6 hours as needed. The maximum dose of aspirin in a 24-hour period is 4 grams, and it should not be taken by anyone at risk for a GI bleed or that are using anticoagulant therapy. Ibuprofen can be taken over the counter at 200 to 800 milligrams. The max dose of ibuprofen is 2.4 grams per 24 hours. And finally, naproxen can be taken about 550 to 825 milligrams at onset of symptoms, and then repeating a single tablet dose, 220 milligrams every 8 hours as needed. The max dose of naproxen is 1.375 grams in 24 hours. Let's move on to the NSAIDs that are available by prescription to treat acute migraine pain. Of the NSAIDs that are on the market, the following have demonstrated the most consistent efficacy in the cases of migraine: aspirin, ibuprofen, and naproxen. Those, of course, are over the counter as well. The 2 NSAIDs that are prescription only for use in migraine are diclofenac and ketorolac. There aren't any studies that compare NSAIDs among themselves for the use of migraines, but we do know that NSAIDs seem to prevent the neurogenic inflammation that occurs in the trigeminal-vascular system, and that's through its action on the prostaglandin synthesis. Historically, opioids and barbiturates have been used for migraine acute pain. Products like Fiorinol, Fioricet, and Zebutal are marketed for that very reason. But all of these have fallen out of favor because we have much better treatments that we can use now, and because we don't want to expose patients to opioids if we do not have to. As well as treating the direct symptoms of pain and migraine, we want to provide supportive care as well. These are non-analgesic agents that can be used for the other symptoms that patients experience when a migraine occurs. The first one is metoclopramide or Reglan. It's an antiemetic, and it works to speed gastric emptying. The other 2 antiemetic medications are prochlorperazine and chlorpromazine. They both work to help with nausea and vomiting associated with migraine aura. You definitely do not want to use either of these medications in elderly patients. I want to reiterate that opioids should not be used for control of pain symptoms with migraine. Opioids have no vasopressor activity, they have no anti-inflammatory effects, and therefore they are really not effective in treating migraine pain. The first class of specific migraine treatments we'll talk about are the Airguns. There are 2 medications in this class, ergotamine and dihydroergotamine. Ergotamine is under the brand name Ergomar, and dihydroergotamine is the brand name Migranol. Ergotamine comes in a sublingual tablet, and despite its use since 1926, data supporting the efficacy of this product is inconsistent, to say the least. On the other hand, dihydroergotamine is available in subcutaneous, an IV formulation, as well as a nasal spray. This one is used more often, and the nasal spray contains about 10 milligrams of caffeine per dose. That's an adjuvant, a booster of the dihydroergotamine component. Patients who use ergots for migraine will typically complain of abdominal pain, weakness or fatigue, maybe some paresthesias and claudication. The rare but serious side effects of ergots are related to their vascular effects: gangrenous extremities, myocardial infarction, bowel, brain ischemia, and hepatic necrosis. Ergots are contraindicated in any patient who has renal or hepatic failure and any type of coronary, cerebral, or peripheral vascular disease. Also, people with uncontrolled hypertension should not take ergots. Now, let's move on to the triptans, another migraine-specific treatment. Triptans work because they are selective 5-HT receptor antagonists. That's a serotonin receptor antagonist. The agents included in this class are sumatriptan, zomatriptan, naratriptan, rizatriptan, almotriptan, frovatriptan, and elatriptan. These drugs are similar in their efficacy and side effects. Drug selection is usually based on the characteristics of the dosage form and the patient preference. A lot of research and development has gone into creating unique dosage forms for treatment of migraine. The first drugs that came out were oral dosage forms, pills that the patient swallowed. And because it can take some time to get through the digestive tract, the onset of relief was less than optimal. And if the patient was experiencing nausea and vomiting, oftentimes an orally swallowed pill wouldn't be able to reach the bloodstream because it would come back up. Now there are many more drugs that are available for treatment of migraine, and the triptans have really gone above and beyond to make dosage forms that get the drug into the system very quickly for immediate relief. Antiemetics, for instance, has a stat dose system. Maxalt has a rapid soluble tablet that's put on the tongue. There are nasal dosage forms and injectable subcutaneous pens. This is a particularly novel delivery system. This is the drug sumatriptan, and the brand name of this product is Onzetra. You can see how the patient blows into the device while the nasal portion is in place. This delivers the drug directly to the nasal mucosa, and it gets into the bloodstream very quickly for a quick onset of relief. All the triptans are really highly effective, well tolerated. They just differ in the onset and their duration of action. Patients that take triptans commonly complain about dizziness, flushing, or a warm sensation. Sometimes it can make them drowsy, and on extreme cases, they might feel a tightness in their chest. These drugs do interact with monoamine oxidase inhibitors, or MAOIs. It's a very serious reaction, and they should never be co-administered. You should also use caution in prescribing triptans to patients who are on SSRIs or SNRIs. In rare cases, the patient may experience serotonin syndrome. In addition to not prescribing to patients who are taking MAOIs, you do not want to give triptans to patients with any history of ischemic heart disease, angina, a previous MI, or uncontrolled hypertension. Because these drugs have vascular effects, it's very important that the patient have no comorbidities in their vascular system. Well, how do we treat patients who are pregnant but also who have migraines? First-line therapy is acetaminophen or acetaminophen plus metoclopramide. And in the rare case, here is a case where we can use acetaminophen with codeine. You'll notice that the Airguns and the Triptans do not appear on this list. Second-line therapy in case a patient is not tolerable of acetaminophen is naproxen and ibuprofen, but there is a risk of miscarriage and birth defects in the first trimester. They're safest in the second trimester to use for the naproxen and ibuprofen. Where once migraine patients were left to treat symptoms once they were onset, now we have a host of preventive therapy that we can offer to patients with migraines. The good news is that approximately 50 to 75% of patients that are given any of these available preventive therapies will have a 50% reduction in the frequency of their migraine headache. The types of medications that are available for preventive therapy are very wide-ranging. So the choice of the agent is really individualized to the patient's specific characteristics, comorbid conditions, side effect profiles, the cost of the medication, and the patient's preference. This is a list of the very common drugs that are used for preventive therapy. These are taken every day, and they're meant to prevent the frequency and the severity of migraines that do occur. There are antidepressants like amitriptyline and venlafaxine. There are blood pressure medications like verapamil and propranolol and metoprolol. And then we have anticonvulsants like topiramate and valproate. You can see these are very different classes of medications that are used for the same purpose. Matching a drug to the patient's specific symptoms and comorbidities is key. Here are some examples of suggested therapy in certain patients. For a patient who has hypertension but is a non-smoker or less than 60 years old, a beta blocker is probably ideal. That would be metoprolol or propranolol. If a patient has hypertension and is a smoker or over 60 years old, the choice would be verapamil. You want to avoid beta blockers in this type of patient because it has been shown they are more at risk for stroke. For patients who have depression, using an antidepressant like amitriptyline or venlafaxine may be dual therapy, in this case for migraine and the depression. Patients who have seizures might be able to benefit from valproate or topiramate. Both of those are anticonvulsants. A patient that has insomnia in addition to migraines might benefit from amitriptyline. It is an antidepressant, but it has a lot of drowsiness in its side effect profile, so it could treat the insomnia as well. Topiramate is a drug that has been known to cause weight loss in patients, and so patients who struggle with obesity and migraines could benefit from topiramate. And finally, if a patient has claudication or Raynaud's phenomenon, verapamil, which is a calcium channel blocker, could help those patients in their therapy for migraine prevention. There are quite a few new drugs that are emerging for treatment of migraine. I want to mention a few now. The first two I'm thinking of are CG RPAs. That stands for calcitonin gene-related peptide antagonists. The two drugs in this class currently are rimegepant and ubrogepant. In random controlled trials evaluating a single migraine attack, both of these medications showed benefit compared with placebo. They both led to greater rates of freedom from pain and absence of the most bothersome migraine symptoms after 2 hours. Ubrogepant is FDA approved and it is under the brand name Ubrelvy. The other drug, rimegepant, is brand name Nurtec. It is currently under regulatory review for approval by the FDA, and it will probably be released soon. The CG RPAs were only studied in short-term, single-episode migraine events. And so we need more long-term data to determine the safety and tolerability in using these medications over time. We don't know how this is going to affect patients that are using existing migraine treatments like triptans. Another class of emerging therapies also targets the CGRP system. They are anti-CGRP monoclonal antibodies. They're considered last resort because they're very expensive and they do require injections. The three medications currently approved in this class are irinumab, fremanezumab, and calcanezumab. The first one targets the CGRP receptor. The other two target the CGRP protein itself. Here's a summary of those three medications. You can see that they are very expensive per dose, upwards of $600. Some patients may be available for a patient assistance program through the drug company. All three of them require injections in the subcutaneous tissue, either in the abdomen or thigh areas. And the most common side effects of all three are injection site reactions. Storage is important for these three dosage forms because they do require refrigeration. The nice thing about these three drugs, though, is that they only require 1 to 2 doses a month. That can be convenient for patients who don't like taking regular medication, but they need preventive therapy. One final emerging therapy is a medication that's used for other things, but now has been shown to have use for migraines. This is the medication commonly known as Botox. It's botulinum toxin. Botox is FDA approved for chronic migraine, so the company has gotten approval from the FDA to use it and label it as such. Botulinum toxin should be reserved only for those patients who have migraine symptoms 15 or more days a month. It's something that, of course, the patient can't administer him or herself. The clinician would administer this in the clinic setting. It's given as 0.1 ml injections in each site, and it's divided across 7 head and neck muscles. I do want to point out there is a boxed warning related to botulinum toxin. It relates to the possibility that the toxin could spread from the area of injection. And the symptoms that have been reported related to this spread can occur even weeks after the injection. The symptoms that a patient might experience are swallowing and breathing difficulties, and they can be life-threatening. So adults who have underlying conditions that would predispose them to these types of symptoms would be at a higher risk. Once a patient has been diagnosed with migraine, it's very important to educate the patient about how to avoid triggers, how to keep a diary of symptoms, and how to assess the severity of the episodes. Then we as clinicians evaluate whether they have mild and moderate symptoms or severe symptoms. Mild and moderate symptoms may be able to be treated at some episodes with acetaminophen or NSAIDs, or perhaps a combination thereof. Patients with severe symptoms should always have Triptans or Airguns as rescue therapy. We should also consider the possibility for one of the many availabilities of preventive medications we can offer patients. For mild to moderate symptoms, the patient could rely on NSAIDs and some supportive therapy in the form of Antiemetics. These are generally all oral medications. In the moderate to severe category of migraine, we use Airguns, Triptans, often Triptans plus NSAIDs, and supportive therapy with Antiemetics. We can use nasal sprays, orally disintegrating tablets, and traditional oral tablets in this stage. A patient with a variable attack pattern can use all of the above, but also we could consider the CGRP class of drugs. In the emergency situation, clinicians in the emergency department would administer IV Airguns, subcutaneous Triptans, and possibly dexamethasone, metoclopramide, prochlorperazine in the IV form as well. For chronic migraines, we definitely want to offer preventive therapy for patients, and choice of these is going to depend a lot on the comorbidities and patient preference. These treatments include beta blockers, calcium channel blockers, antidepressants, anticonvulsants, monoclonal antibodies, and in some cases ACEs and ARBs. Some patients have even found benefit with herbal remedies like butterbur, feverfew, coenzyme Q10, and magnesium supplementation. It's controversial, to say the least, to use alternative medicine instead of studied therapies for migraine prevention, but you may have patients asking about them, so you should know that these are a few that have been studied in migraines. I'm Dr. Amber Cann, and I thank you for joining me for this review of medication management of migraine.